So I just want to remind everyone that we're streaming on that new YouTube channel. So it's been created for Metro Health. So anyways, let's get into the agenda. So review the minutes of October 23rd. I just need a motion to approve the minutes.
So approved. So,
I have a second.
Second.
All in favor?
Aye.
Aye. All opposed? Okay. I'm now going to turn it over to Joe.
Thank you so much, and thank you for everybody here today. We do have a packed agenda, so we want to make sure we stay on time as we go through. We always like to start with our true north, grounding us that every patient we touch will receive equitable, safe, high-quality, patient-centered care to afford them the ultimate patient experience. And that's truly what this committee is about, in ensuring that every employee is working towards this true north and they all have a voice. So we're going to get started. Stacy, do you want to introduce our video that we have?
Sure. I'm the Director of Patient Safety, High Reliability. So there has been an ask for us to share a story as relates to a near miss, a great catch. But I thought that for this first meeting, that I would actually take the opportunity to explain in a video with Dr. Golub of what a great catch near miss is. The great catch near miss, a near miss is a patient safety event that is caught before reaching the patient by either process, person, or chance. This is what helps us to drive a highly reliable organization. These are truly the learning opportunities. This video here will be then shared with various education and training, and at our next board meeting, we will share a near miss story of what the incident was and the work that was done to improve. Dr. Golub?
So Stacy is a movie star. I am not. So, and I am struggling to know that this is being streamed on YouTube. Here we go.
Hi, I'm Joe Golub. I'm the Executive Vice President, Chief of Quality and Safety here at Metro Health, and I'm with Stacy Booker, our Director of Patient Safety and High Reliability. And we wanted to talk to you a little bit today about reporting, and specifically near miss reporting or great catch reporting. Stace, what's a near miss?
Near miss is a patient safety event that is caught by either a staff member, a process, or by chance prior to reaching the patient, so that the patient will not sustain any harm.
So these events are extremely important because, again, it's a proactive way that we're identifying issues at Metro Health. It's helping us find solutions to things before they reach the patient. So as an example, we had a report of a event that came through where a nurse was about to give a medication, had gone through all the checks, and when she used the barcode scanning, it alerted her that this was the wrong patient. This nurse reported that to us and showed how these barcode the scanning helped her. And then we've been able to look at the process to find out where we could have maybe intervened even earlier to prevent it from even making it to the patient's bedside. And this isn't just an inpatient piece. This is an ambulatory piece reporting, just as important in our specialties such as radiology and the laboratory. All of these areas can report near misses, and simply by going to the origami system, and there's actually a near miss event category where people can click and put in your near miss for us to evaluate.
And near miss great catch is not just for our clinical teammates, it's also for our non-clinical team. For example, you're delivering a dietary tray and you recognize that when you go to do the patient identifiers that the tray does not match the patient. We want to hear from you. So everyone here at Metro Health is empowered to report the near miss great catch.
So Stace, when somebody does report a near miss, what's the next steps that happen?
So the patient safety team reviews all of the safety events. We then take a report of all the near misses from the month, and then we send them out to our patient safety committee. Our patient safety committee then votes on the great catch of the month. We work in collaboration with the Office of Professional Affairs. Those individuals are recognized as either an individual or as a team. We also last year incorporated the Great Catch of the Year in Patient Safety Week, and we'll do the same this year to really just allow caregivers to understand what the Great Catch is and allow them to vote on the Great Catch of the Year.
So last year we saw over 2,100 near misses reported throughout the organization. And this is very important because what that helps me see is it helps us see that we have the psychological safety to report. We're willing to say that I almost made a mistake, or in some cases, I made a mistake. But yet we caught that before it reaches the patient. And therefore, our goal and our true north of Metro Health is to truly eliminate patient harm. And this is definitely one of the most important things that we can do as an organization is the report.
And as we strive to be a highly reliable organization, it is the near miss, great catch, that helps us do so. We hear from the frontline staff. The frontline staff helps to make the improvement. And when you see that, more people are more apt to report those low harm events and are much more at ease when we do have to discuss something that has led to patient harm. But are these events that really help us achieve our true north and become a highly reliable organization.
And you may look at this event and say to yourself that it's a small event that happened on my floor, but I can tell you after doing this for so many years that this is happening other places. It's happening in other areas of the organization. And your near miss report can change the way we do something throughout the entire organization to keep it safer as we work towards that true north of eliminating patient harm.
So near miss reporting is obviously very dear to this committee and to this to what we do in patient safety. Now that we've given you sort of an introduction into those moving forward, we'll be alternating a great patient story with also a caregiver giving a great catch and showing what the organization has changed as a result of that. Thanks, Stace.
Thank you. She'll be available later to sign the books.
That's right.
So Joe doesn't know this, but I of course have an Army story to tell. So the division commander in the Army, one of the problems the U.S. Army had, actually the Armed Forces has post our conflict in the Middle East, was the increased rate of suicides. So as a commander, we had to report on a monthly basis our suicides per month. So I took the near miss concept from my previous jobs and had all my commands start reporting near misses. So then we were able to intervene and identify common causes for those potential suicides. I got summoned to FORCECOM headquarters because the commanding general was very concerned about the number of near misses we were reporting, even though our total number of suicides were declining. So the whole concept behind a near miss is to prevent the suicide or to prevent the incident and identify what things were happening that can be changed to prevent them. So for me, it turned out to be a very valuable resource because it protected individuals that potentially could have committed suicide. So that's an example of how you can take a near miss strategy and turn it into a win. So I'm very confident that you're going to be hearing stories about these near misses and good catches in the future that are going to prevent harm to our patients. Questions? All right.
Okay, so in your board books, there is what we call our QAPI plan. The QAPI plan does not require a resolution, but rather it's a summary of the quality safety experience group, the committees that form the Institute of Patient-Centered Excellence and reporting of quality improvement projects. The QAPI plan is something that the Joint Commission asks for when they get in, and we were certainly just complimented on our QAPI plan at the recent Joint Commission survey. So that is in your board books. We review that every year and discuss that and give that to you every year at our first board meeting. So next, we're going to move forward with Dr. Hecker. Dr. Hecker is here to present our antibiotic stewardship program. And Dr. Hecker, I will advance your slides, including the two animations that you have in there. So, we're good to go.
Thank you for inviting me to talk about our stewardship program. I'm presenting really on behalf of a group of people that contribute in different capacities to this program. Next slide. It's been about 7 years since I presented to the board, so I thought, it's been a while, so I thought I would take some time to briefly talk about what is a stewardship program and what is its mission or purpose and why it's needed. And so the purpose or mission of antimicrobial stewardship is to implement interventions to optimize the necessary antibiotic use and to decrease unnecessary antibiotic use. And that really contributes to the provision of safe and high quality patient care and population health. So why do we need an antimicrobial stewardship program? Firstly, antibiotics are very commonly prescribed. So it's estimated that about 50% of hospitalized patients receive at least one antibiotic during their hospital stay. And that's a lot, but it's even more so in the outpatient setting. So about 236 million antibiotic prescriptions were prescribed basically in 2022. And not only are antibiotics commonly prescribed, but they're also commonly prescribed suboptimally. So again, it's estimated that about 56% of inpatient antibiotic days were either suboptimally prescribed or totally unnecessary. And in the outpatient setting, it's estimated about 25 to 30% of outpatient antibiotic prescriptions were inappropriate or not necessary. So not only are they commonly prescribed and commonly suboptimally prescribed, but antibiotic use is associated with significant adverse effects. And it's estimated that 20% of patients who are hospitalized and receive an antibiotic suffer a serious adverse effect. And some of those adverse events are illustrated on the slide here. So antibiotic resistance, Clostridioides difficile infections, acute kidney injuries, allergic reactions. We see these related to antibiotic use not insignificantly. Went too fast. It's also estimated that about 145,000 emergency department visits occur every year due to adverse effects from antibiotics, and that does not include antibiotic resistance or Clostridioides difficile infection. So there's a lot of potential adverse effects from antibiotics. The first two, antibiotic resistance and Clostridioides difficile infections, they affect not only the individual patient, but can affect the entire population. And that's because these infections can be transmitted to other people, both in the inpatient setting, in the outpatient setting, in the community. So this really affects the population as a whole. So it's important that we get this right. And this all is associated with a significant amount of potentially, unnecessary healthcare expenditures. Next. So if that's not enough to convince you that we need an antimicrobial stewardship program, basically it's required, okay? So the Joint Commission in 2016 required that all acute care hospitals have an antimicrobial stewardship program. In 2020, the Joint Commission required that all ambulatory healthcare settings have an antimicrobial stewardship program. And the Centers for Medicare and Medicaid Services also listed as a condition of participation. There was the animation. Okay, so on this slide, I just show you some of the core elements of an antimicrobial stewardship program. On the left really are the CDC kind of core elements of antimicrobial stewardship, and these have been incorporated into the Joint Commission standards. On the right side is what we at Metro Health are doing to kind of adhere to these elements of a stewardship program. So starting with the top, hospital leadership commitment. We have been fortunate to have a formal program since 2012. And I'll say that we were one of the first institutions, if not the first, in this area to have a formal program that was supported by leadership, both financially and conceptually. For accountability and pharmacy expertise, we have a co-leader, so I am the physician leader, and then there's a pharmacy leader, Andrea Sohn. We lead the program together. And we get a lot of support from pharmacy at various levels, and I've listed some of the people on this slide. In terms of tracking, we monitor antibiotic prescriptions through internal data as well as external data, the National Healthcare Safety Network, and the Vizient databases, and they allow us to benchmark our antibiotic use. We also track C. diff rates through infection prevention. We look at antibiotic resistance rates over time, so we do a lot of tracking. Reporting and education, we do that continuously, honestly, on a daily basis. And this is through our prospective audit and feedback. We present frequently to different divisions, departments, and for the entire medical staff, we give an annual presentation about antimicrobial stewardship. So most importantly, though, is action. What do we do to really improve antibiotic use? And that's the next slide. So I'm just going to go through briefly what we do, and I'll start with the adult stewardship side of things. The bulk of our program really is this prospective audit and feedback, which involves, we review patients' charts for certain conditions or if they're on certain antibiotics, And we review to see if there are opportunities for improvement in care, improvement in diagnosis, or improvement of antibiotic use. And these are the things the criteria we use for chart review. There are certain high-risk antibiotics or high-cost antibiotics, positive blood cultures, positive Clostridioides difficile tests, patients on certain antibiotics or on certain medical services. We review those charts Monday through Friday, and we make interventions in a timely fashion directly to providers, in real time. We also create guidance documents for infectious disease syndromes. We support antibiotic management questions from unit-based pharmacists or other providers. We help manage antimicrobial drug shortages, which are unfortunately fairly common nowadays. We review antibiotics that are in new and existing order sets. We collaborate closely with the microbiology lab, which is essential for our work. And then we also kind of perform one project at least every year in depth to really help alter and make sure we're adhering to evidence-based practices. And then for the emergency department, we have 3 emergency department pharmacists who have about 50% of their time allocated to doing antimicrobial stewardship, and their activities are shown on this slide. We have a culture callback program where they review positive culture results or microbiologic tests, and if they see that a patient has not received the appropriate antibiotic treatment, they reach out to the patient, tell them like, oh, we need to start this antibiotic, or you need to stop this or change to this, and give them the antibiotic prescription. And this is through a collaborative practice agreement that we have. They also review pre-procedural antibiotics for select urologic procedures, and we did this in collaboration with their urology department. They're part of the sepsis management team and the sepsis committee, trying to optimize our processes and outcomes for sepsis, review order sets, and do projects as needs arise. And pediatric neonatal stewardship, we have 1 pharmacist, and about 20 to 25% of her effort is allocated to antimicrobial stewardship. She rounds with the neonatal intensive care unit and helps to provide guidance on antibiotic use, participates in development of guidelines related to antibiotic use, and again, does some projects depending on what the needs are. So approximately of the 12 elements in the Joint Commission standards for antimicrobial stewardship, 1 is really doing these in-depth projects to really optimize the evidence-based practices for certain infectious disease syndromes and antibiotics. So I wanted to share with you 1 project that we did very recently. We did a quality improvement project in collaboration with anesthesiology and allergy, where our goal was to optimize cefazolin use for surgical prophylaxis in patients who were allergic to beta-lactam antibiotics like penicillin primarily. And the reason we did this project is that cefazolin really is the preferred antibiotic for many surgeries for pre-surgical prophylaxis, but many studies have shown that cefazolin is often unnecessarily avoided in patients with penicillin allergies. So there was data suggesting this was a problem on a national level. We looked at our data. We also found that we could do better. So we kind of collaborated together, and we did a number of interventions. We, developed algorithms, multiple educational sessions with pretty much all of the surgical specialties, perioperative services, with a lot of people, made some improvements in the electronic medical record system, and also did some of this prospective audit and feedback on patients who could potentially have gotten cefazolin and were not ordered that medication. And so next slide. So I want to show you some outcomes related to this project. So this graph shows you the percentage use of different antibiotics in patients with beta-lactam allergies, so mostly penicillin allergies, who underwent procedures. The green line is when we started our interventions and realized that not all of these procedures would cefazolin be the drug of choice. So sometimes, it's appropriate not to use cefazolin, and sometimes the allergies were very significantly severe that it wouldn't be appropriate. So this should not be 100%, I guess is what I want to say. But you'll clearly see the blue line We look at cefazolin use, and it significantly increased after our interventions. And the orange line, which is clindamycin use, significantly decreased after our intervention. And it's sustained here, and this is out through December 2023, and we have more data through 2024. And I will note that clindamycin is significantly associated with higher rates of surgical site infections, higher rates of Clostridioides difficile infections. I mean, this is really important that we reduce the use of clindamycin. Next slide. We also found that by doing this project, this resulted in higher rates of appropriate timing and dosing of our pre-surgical antibiotic prophylaxis. Next slide. Next slide. Okay, so for future directions, there's really a lot more work that we'd like to do in this space. And two of the main things are that we want to optimize and expand our pediatric and neonatal antimicrobial stewardship, as well as our outpatient antimicrobial stewardship activities. And regarding our pediatric neonatal antimicrobial stewardship, we do have the one pharmacist, but she has no pediatric infectious disease support, and an adult infectious disease physician cannot give excellent advice for neonatal intensive care unit patients. I mean, we are just not trained to do that. And right now we don't have a Metro Health pediatric infectious disease physician. And we utilize the services of the University Hospitals Rainbow and Babies ID physicians, but they do kind of remote consultations for the NICU and a little bit of outpatient clinic time. But it would be very nice to have at least some limited effort allocated to one of them to provide some support for our neonatal and pediatric stewardship. And I say that too because we have seen some higher rates of antibiotic prescriptions in our neonatal intensive care unit and higher than what's expected for us. And then secondly, in the outpatient setting, again, this is a Joint Commission requirement. And we are doing some, we do some through our emergency department and through our adult stewardship, but we really would like to expand this further and really meet our commitments really to meeting this element as much as we can. So having a little bit extra pharmacy support in this setting would be very helpful. And I think in the interest of time, I'll stop. I think you have some other data in your handouts related to some of our other outcomes in terms of antibiotic resistance, some cost data that are just specific to the antibiotic use and don't really account for all the other cost savings that we provide. And I'm happy to take any questions.
You mentioned education was a key component of your success here. I'm curious as to how compliant patients are in this attempt to talk them out of getting antibiotics.
Yeah. That's a challenge because I take care of outpatients as well. So it is difficult sometimes to get patients on board with the concept of antimicrobial stewardship, and you can't sell it to them based on antibiotic resistance. That doesn't really work. But I think times have changed a little bit. Honestly, I've been in practice over 33 years or so. And I think even in the community, there is an understanding that overuse of antibiotics leads to adverse outcomes, that people can get diarrhea, they can get allergic reactions, they can develop all kinds of problems. And there are more tools nowadays too to help how you can talk to patients about it. And we have resources from, AHRQ, from different agencies provide us with resources to give to patients to say, really, this is good for you. We're not trying to withhold something for you. We're trying to optimize your care. So yes, it's a challenge, but I think we are getting better at it.
I have a follow-on question.
Yeah.
So do you have any examples in EPIC, either for the inpatient or outpatient side, where you're doing directional advice to a prescriber, either in an inpatient or outpatient setting, to kind of address? So
yeah, so informatics certainly is a nice way to do stewardship, and we try to implement that as much as we can. So some examples of in EPIC, how we would do this, certainly through all the order sets. So as I mentioned, we review a lot of every order set that has an antibiotic in there. And so we try to make it easy for the provider to order the right thing, the right antibiotic, the right dose, the right duration. So all that is embedded in the order sets.
and review, or is it automated?
That's automated, yeah.
So as they go to order, it'll kind of attempt to redirect.
Right, so some of it is, it's in the order set and, you know, it's clearly listed what you need to do. And then other things are like, will alert the provider if they're doing it wrong. You know what I mean? Like if they give the wrong dose of something, you know, we'd have an alert in there or something like that.
Are there any that require another subspecialist sign off before it gets ordered?
Like an antibiotic, do you mean? So we do have pre-authorization, like certain antibiotics you cannot get without talking to us. You know what I mean? Either infectious diseases or antimicrobial stewardship. Some we allow like a first dose or two, and then we review them on stewardship. And then if we feel like it's not necessary, then they need to get a formal ID consult. So yes, there are different levels of restriction as well.
And I can tell you just from having been on the receiving end of this, how incredibly helpful it is. Because they will message you, but they will also provide you then the resource. Like, here's the link to the most recent article, you know, or they'll call and say, hey, do you have any, you know, we noticed you have this patient on this, you know, blah, 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 right? It is very interactive. It's not just, we are the antibiotic police. It is, we are your partners in doing what's right for the patient. And I think it's that approach that has led this program to be so successful, because now I find we proactively call, we reach out, we ask questions, right? Like it's achieved that level of interaction that we're all in this together and rooted in what's best for the patient, as opposed to, you can't have that, you know, but I want it, you know? Yeah.
Absolutely. And that model has definitely shifted. We're not the police. You know what I mean? We are here to provide the best care for our patients in collaboration, just as you said.
Any other questions? Thank you for your time. Appreciate it.
All right.
Okay, so for our next topic, we have Dr. Ardell, our Chair of Neurology here. He's going to talk to you a little bit about our stroke certification. There is a resolution that will be tied to this regarding the accrediting agency for our stroke program. Dr. Schrock is here too. I thought he was going to be online, but here he is.
He's really hologram.
Yeah.
Right. Thank you so much for your time this morning. And I'm so glad that my co-director of the stroke programs, Dr. Schrock, was able to join me. So we've been certified as a comprehensive stroke center since 2014. And we've been certified by the Joint Commission. And what a comprehensive stroke center is, it's the center that's capable of the highest level of stroke care. In 2019, our community EDs at Parma and Brecksville were certified by the Joint Commission as stroke-ready emergency departments. And we changed gears a little bit in 2021 because we ended up certifying Parma, Brecksville, and Cleveland Heights emergency departments with a different company. So next slide. So ACHC is the company that I'm presenting to you. And this is a collaboration or a merger between two certifying companies, the HFAB, which is the original hospital certifying company, and HCHC. These companies had very different beginnings, but they merged in 2020 to provide certification, just as the Joint Commission does. So we felt that the ACHC philosophy was a little bit more in line with the philosophy of the stroke center. So next slide. So part of the problem is that the Joint Commission requires specific minimums. And these are minimums that affect certain diagnoses and then also procedures. And as you see in the graph, we are the smallest of the stroke centers in the region, and we are affected by externalities. So if you see with this first start in 2014, that is when UH purchased several hospitals, and that really affected our stroke volumes. And then you can see also in the second start that another purchase by UH affected our stroke volumes. Essentially, the total number of stroke patients is somewhat fixed across the region. And as a proportion, some of these diagnoses and procedures that require minimums are pretty small outside of this entire stroke population. So we being the smallest, are very much affected by what's happening in the region. Next slide. So we were last recertified as a comprehensive stroke center last year. And that certification was based on our volumes through Q2 of 2024. But moving forward, we are at risk for losing that certification because the minimums are not negotiable. So if you look at the chart on the right-hand side, we are good with IV thrombolysis. We provide a lot of thrombolysis, so we are not at risk there. We are at risk in two places. If you look at mechanical thrombectomy, we actually met the minimum. However, we did not meet that per physician minimum of procedures. So you can see that one of our physicians had 27 and one of our physicians had 39 over the 2 years, and that does not meet the criteria. Also, if you look at aneurysmal subarachnoid hemorrhage, we did not meet the minimum number of procedures. With aneurysmal subarachnoid hemorrhage, because of a lot of CTA use, people get diagnosed with these as incidental findings, and then they are fixed prior to becoming a ruptured aneurysmal case. And so I think that the population of those patients is going to continue to decrease, and there's not so much that we can do about that. Next slide. So we have several concerns about the Joint Commission minimums. First of all, we are not sure that they actually reflect quality of care. They don't have anything to do with people's training, procedural training, and a lot of the specialty associations are not weighing in as to what the minimum number per year is required to maintain competency. And we are also concerned that these minimums are not open to discussion. And essentially, we think that that's the first problem. Second, next slide. And of course, we're concerned about Metro Health. If we were to lose our certification as the Comprehensive Stroke Center and became a primary stroke center, which is the level below a Comprehensive Stroke Center, that would really affect our mission, and it can have cascading effects across the institution. So we would lose the sickest stroke patients. We would not be able to advocate for them. And then we would lose talented providers. And that might domino into other areas, such as neurocritical care, as well as neurosurgery and trauma in terms of outcome and recruitment retention. And I think we would lose our reputation. Okay, next slide. So our recommendation is to certify our Comprehensive Stroke Center with ACHC. We already have beta tested the relationship. We were certified by them for our community EDs in 2021. We were recertified in 2024. We like their approach, and they approach the minimums differently. So essentially, they direct each institution to present the minimums and to justify them and to talk about how that affects the outcomes. And they are really concerned about outcome rather than meeting, an arbitrary number of minimums. Next slide. So what are some of the concerns about switching from the Joint Commission to ACHC? Well, loss of EMS traffic. So we kind of tested that idea, but with our community EDs. So as you can see in the graph, the teal bars are the numbers, total numbers, and then the line, the yellowish line running at the bottom are the numbers that are of stroke patients coming from the community EDs. So you can see in 2021 was the year of our certification, and you can see the numbers coming from the community ED as a percentage, as well as the raw numbers continue to increase. So the question is, how do we also mitigate this potential loss of EMS traffic if we were to switch the certification for Maine? So we already have a great collaboration with Cleveland EMS because we provide medical direction for them, but we also have other opportunities to involve other independent EMS companies and fire stations. And so we do a lot of this kind of outreach, and we can enhance that by providing open houses, town halls for EMS. We can also advertise legitimately with Metro Health being the only center that actually has all of the EDs certified. Okay, and so we also contemplated and sort of did a little bit of research into perhaps also certifying one of our community hospitals as a stroke-ready hospital or a primary stroke center, okay? We also were thinking and did some research about a mobile stroke unit, which at the moment did not seem like a feasible way of moving forward. So we have some things that we can do to try to mitigate this potential loss. Next slide. So what about the potential negative effects on our reputation if we switched? Well, we're not the only ones in the state of Ohio that would be certified as a comprehensive stroke center through ACHC. And we continue to hone relationships with the stroke programs at UH and CCF, and maybe that might alleviate some loss of reputation related to that. We also hone relationships with ODH, and we also are sort of expanding our footprint in the community by providing a lot of stroke programming and education. So I feel like this is something that is not predictable, but we can do what we can to try to prevent this loss of reputation. But I also feel like we don't really have a choice at the moment. Next slide. We would have to do this year because with the numbers from January and part of February, we may be at risk even during the intra-cycle phone call at the end of this year. And that's it. I'll take any questions.
I'm drawing on my experience in Lakewood with the EMS, and I was glad to hear that conversation because it's a very interesting one, complicated as you alluded to, where mobile stroke unit arrives from the Cleveland Clinic. It sits out in front of the patient's house for 45 minutes while they're trying to figure out what's going on, block or bleed, and who has the resources available at that moment in time. So there's a lot of decisions being made. I mean, it's literally sitting on a side street in front of a house. And I suspect you're trying to influence those decisions at that moment in time. So I'm wondering, there's three parties making the decision. Patient, where do you want to go? EMS, where do we go? Where can we go at this moment in time? And then the comfort level afterwards with all those decisions as they talk amongst themselves in a firehouse and other places. So I'm thinking that, the Cleveland Clinic used to arrive at community events with their mobile stroke unit for show. And you show up and you see it and you learn about it and you increase your confidence and knowledge of how that might be a critical option for you. So I know the stroke unit is probably expensive, but I've never been convinced of how efficient it is. It's got to be in some proximity at that moment in time to be available. But there may be an opportunity to do a little bit of a show to show it could be a van with other things inside to communicate what we need to. But I think community comfort and confidence is a critical element of this urgent decision-making process.
I'm glad you said that because I think we have an opportunity, especially with Glick being, the brand new hospital. We have an opportunity to really enhance that EMS collaboration by inviting them over here and seeing all the things that we have, the new angio suite, and et cetera. So I think that's great. So in terms of looking at stroke, for ischemic stroke, which is the greatest percentage, EMS traffic is directed basically to the nearest hospital that's able to take care of this patient, okay?
This is the bleed?
The ischemic, the blockage type.
Okay.
And so if let's say, Metro Health and UH are equidistant, right? And it's the same level center, then maybe there'll be more of a chance for us to get that patient. That will be the idea behind certifying one of our community hospitals or one of our community EDs as a higher level stroke center, right? So then they can choose between UH and us, for example. So that's one option. For the bleeds, time is a little bit less of an essence. So that's an opportunity where we can actually increase the catchment because we could reach out to hospitals that are a little bit further even. Because then we can say, hey, we have great aneurysmal subarachnoid care as well as ICH care, hemorrhage care, and why don't you bring them to us? And we're always open, right? So that's an opportunity. John, please, because this is more of your area.
Yeah, so I work with the MTSU unit from the Cleveland Clinic. I was there when they helped develop it. I'm kind of their liaison through Metro or through the clinic. So if they have issues, if there's problems. So MTSU basically, the clinic, the patient guides where they want to go, or the family member guides where they want to go. So when they pick them up, if they want to go to UH, they'll take them to UH. If they want to go to the Metro, they'll go to Metro. Clinic, they'll go to the clinic. I will say this about the risk here. So should we lose our certifications at Comprehensive Stroke Center? In 2016, after the major thrombectomy trials came out, the Cleveland EMS arbitrarily actually just decided they were going to take their stroke patients to comprehensive stroke centers. There's 3 of them in Cleveland, UH, Cleveland Clinic, and us. Because basically they didn't want to try to decide, is it a minor stroke, is it a major stroke? A comprehensive stroke center can do everything. We can do everything. So it's a no-brainer. They don't have to think, well, Fairview might be able to do it. Maybe they can't do it. You know, Lutheran, maybe they can do it, maybe they can't do it. They don't want to think about it. They're just going to take them to a comprehensive stroke center. So for us, that's about 500 to 600 patients a year that we would potentially lose. And it's not just, you know, sure stroke, but it's also weak and dizzy, altered mental status. I mean, there's a patient, 92-year-old downstairs in the ED right now, subarachnoid hemorrhage. She came in as altered. Didn't really even look like a stroke, but that's where she's at. But that patient, we're going to lose that EMS traffic should we lose our certification. They're not going to ask where we got certified from. They just want to make sure that we're certified and that we can actually do what we say what we do. But again, because of these arbitrary numbers, which aren't really evidence-based, that puts us at risk for losing our certification. That's a big problem if it would occur.
So for me, my comments aligned. The average consumer doesn't know the difference between TJC and ACHC, and ACHC is really for smaller volume facilities. So that aligns to Metro right
That's the
now.
block.
The HCHC is the accrediting body.
Accredited, okay.
So nationally, they're both not-for-profits. You know, TJC has this little side business where they sell a whole bunch of other certifications. And then you get to market them in the community. So that, to be honest with you, that's my biased opinion. It's a little, I don't want to call it a side hustle, but, and they're, you know, going back to volume issue for them, you know, if you have an interventional radiologist that requires to do so many, you recruit a new radiologist, your volumes may fall below the threshold only because you're bringing in more resources to be able to provide more care to the community. And during that time period, then you could lose your certification. So for me, going to ACHC provides Metro the ability to maintain their certification. And as long and the outcomes are in measure. It's not really whether you're TJC or ACHC. What's important is what are the outcomes? And are your outcomes comparatively where they should be? And are you a top decile performer? So as long as the commitment's going to be, you're going to remain a top decile performer, doesn't matter whether it's TJC or ACHC. And the average squad's not going to say, oh, can't take you there, you're ACHC. So.
Yeah, you mentioned that you worry, and you put that graphic, I think one physician had 27 cases versus 36. You worried that if they're not going to get enough, we're going to start losing staff because they're not getting the experience that's required. When I was doing transplant, I know these are not elective procedures, but we would actually share cases and have backup call. What kind of provisions are you doing that will allow these individuals to make up the required cases?
So there was one year when we were really at risk. And what we did is we worked with the interventionalists. We even went as far as having them sign up for locums. Because the Joint Commission didn't care where they got the cases. That did not work out. That was a complete bust. And so there's really not a great opportunity for them to go do these emergent cases. But we did beta test this idea by having one of them who was more at risk do a locums, and that did not work.
And if I can, I think you're really spot on. That the point here is the outcomes, right? The patients don't care, right? At the end of the day, this is about a patient, and our outcomes can go toe to toe with anybody. That's what this is about, right? So I think that this is a wonderful idea. We are always looking at it. We've looked at how do we train the next generation of people to do these procedures? Because we have people that are getting near end of career and thinking about retirement, right? So how do we do it, and how do we do it in a way that we don't take away cases because we're gonna fall below the threshold per physician, right? I think this just opens up the opportunity for us to always be prepared, and our outcomes are excellent. And I think that's the story we need to keep telling again and again. We're a comprehensive stroke center. We can take care of you soup to nuts. We could take care of your stroke. We could do your rehab. We've got you, right? So I'm really proud of this team and the great work that's been done. And I fully support this.
So much, appreciate it.
If you have any questions.
Yeah, just a final point. I'm still thinking of the street level view. The EMS decision is really gonna be, what's our quickest turnaround? Can we get there? Can we get this patient offloaded and get back on the street? So, I mean, at the street level decision, that's a factor. Now, you know that. So how we can do a better job of helping those folks understand by virtue of our ER efficiency. Because Fairview, oftentimes, which is 3.8 miles away, this is 7 from Lakewood. Downtown is 7, UH is 9. So you're really in a really multi-factor decision here if you're sitting on the middle of Lakewood, Ohio. So Fairview often has a reputation of being too busy. Now, of course, it depends on the time of day. But the real key is, where can I get as an EMS operator? Can I get my squad in and back out?
So it's super fast here. You wanna talk about that?
Yeah, I mean, every emergency department's busy right now. I mean, it's just the nature of the business, but, I mean, yeah, they're not waiting. They come in, they drop off, they give a report, they go. You talked about the stroke bus. If you want to buy one, I got a guy. Let me know. $2 million, it could be yours. About $1 million a year to staff it. But yeah, so it's, again, we do have an ace in the hole. So I mean, the director of Cleveland EMS, Craig Bates, one of my partners. So I mean, we have direct access to Cleveland EMS and with their education and their policies. But again, they're not going to play favorites, but they are going to try to go, again, like I said before, they're not going to overthink it. They're going to go to the comprehensive stroke center. So because they don't want to try to, again, so Lutheran's not getting these potential strokes. Fairview, if it's West Cleveland, like West Park, not getting these potential strokes, they're bringing them to us. But again, that's where at risk if we lose our status or certification.
And I also wonder if there is an opportunity to even to continue to hone the individual relationships with EMS. I was actually an EMT before I became a physician. And it was really important to feel like you were providing value to the receiving center. And so when I was at the University of Chicago, we did borrow this idea, and we had a collaboration whereby we would invite EMS crews to come, and the patient that they carried for us that had a great outcome would then talk to them and sort of, thank them for their service. And so we can certainly think about upping that kind of relationship. Everyone's busy, right? But if we do it once a quarter, maybe that will sort of influence that decision, right?
We do have an EMS liaison, David Yarmish, who will provide follow-up for squads, the current strokes that came in to provide. And plus, I mean, be perfectly honest, they'll just be back in 20 minutes with another patient, so they'll see me and say, what happened? And then, maybe we did this, we did that. So there's an ongoing communication. Plus, we provide education for a lot of these groups, not only in Cleveland, but also in the suburbs. So we'll provide stroke education for the EMS groups throughout the year.
I would encourage you to address city council in one of their formal meetings. Often they're videotaped, but that's another key opinion context of increasing the comfort level of the thought leadership in the community.
All right. Thank you very much. Appreciate what you do each and every day. All right, at this time, we're going to move into executive session. I would like to ask for a motion to move into executive session to discuss hospital trade secrets as defined by Ohio Revised Code 133.61 and to consider the appointment, employment, dismissal, discipline, promotion, demotion, or compensation of a public employee, for the investigation of charges or complaints against a public official, and to conference with the public body's attorney to discuss disputes involving the public body that is subject of pending or imminent court action as defined by ORC 121.22G. Do I have a motion to recess an executive session to discuss these matters?
So moved.
For a second? Second. I will do a roll call. Sharon?
Yes.
Dr. Dr. Walker, sorry.
A lot of doctors.
Michael and Ron, yes, okay. At this time, we will ask the public service
fully someday.
For the rabies guys.
What the border.
So she gave it without, no, she followed.
What
So she didn't follow the process.
Correct.
Okay.
Common sense.
How are you?
says-
Living the dream.
I was gonna call you. So I can call you tomorrow.
Good.
Show me glass.
Right.